welcome. This is to another of our talks for the Women's Health Osteopathy Facebook group for all of our general practitioners. And today we're talking to Liz Howard, who is down in Australia. So welcome, Liz. And she's going to talk about a variety of things, but I'll hand straight over to Liz so that she can introduce herself and then get going with her experiences in women's health, which are extensive and great. So we're looking forward to it. Over to you, Liz.
Thanks, Carolyn, and thanks for having me talk today. So I'm an osteopath, and I think I have about 21 years of experience, and I've got a degree in a master's in pain management as well. So I work at the Women's Health and Research Institute of Australia in Sydney, and that's a big interdisciplinary group. So the main practice is actually gynecology. But we do gynecology, pain medicine, women's hormones, and we have, say, 7 doctors. They're all tertiary specialists and they're all dual qualified. So some are pain medicine and obs-gynae, some are gynae and reproductive endocrinology. We have another who's a vulval specialist as well as a ultrasound specialist and a gynecologist. And we have also a big allied health team. So we have psychology, and we have pelvic floor physio, and we have osteopathy. And we did have acupuncture, but she moved away, unfortunately. So it's a really big collaborative team. We have monthly meetings where we discuss difficult cases, and that's really great to get the input of all the team.
Yeah, no, that's great. So when you've been working in that environment, it's obviously quite different to working in as a sole practitioner. So did you have, what challenges did you find migrating across, so to speak?
Early on. Yeah, so I, going from general practice to the Women's Health Institute, it was, that was probably 9 years ago. So it was a little challenging in that you thought, oh my gosh, I don't know anything. But then when you get in and meet the doctors, speak to them, they speak to you about the same patients and be happy with our input. So it seems daunting, but it's actually not, because the really difficult patients actually do really, really well with osteopathy, and a small amount of treatment can mean a lot to their function and to their pain levels. So so that was probably a challenge. I thought there was a challenge, but it actually wasn't.
And at the end,
yeah.
So
That's
what do they use you for then? So you know, when difficult cases, what are the sorts of patients they seek you out for?
That's a very good question, and that's actually what I did my learning. What do you call it? Independent learning project on when I did my master's, because it's such a melting pot of patients coming in. I mean, most of them are women. We do see men with pelvic pain too, but that was exactly my question. Like, how do the doctors particularly decide who sees who? Because patients obviously don't have endless funds. I worked a lot with Professor Van Kai. So he's a gynecologist and a pain medicine specialist. Yeah, so we work together a lot, and so I sort of nutted out how his diagnostic model and how he examines a patient, and then how he decides who they see. So basically, the way they decided to get osteopaths in the mix is they started initially with hormones and pain, gynecology. They added pelvic floor physio because they already knew that as soon as you've got pain, the pelvic floor jumps on. They need that. And then they actually asked the physios, we need someone who knows the external pelvis, the mechanics and the treatment of the external pelvis really well. And the physio said, well, don't get a physio, we need an osteopath. So that was really the key to osteopathy starting in this scene, and the patients just love it.
So that's really, sorry, go on.
If you have a question there, actually.
Well, I was going to say it's really interesting about them wanting the external pelvis, so that they had a view then, or they were quite comfortable with the idea that if you like, what we'd call the biomechanical somatic pelvis is quite relevant to the whole story, even when there's also visceral pain problems.
That's right. So Profank, he trained in Belgium and in Germany, and then in the States, and he trained actually off I think it was a German gynecologist, and he examined the abdominal wall, examined the sacroiliac joint, examined all the musculoskeletal as well, which is quite rare, I think, in a gynecologist. So that's been his training. So he's always examined the patient as a whole. And and that's why he thought, so when they come in and he examines them for pelvic pain, he will examine, distal neuralgia type points, other areas for, other musculoskeletal, but particularly, spinal and pelvic girdle, leg lengths. He does, active straight leg raise, load transfer test.
Yeah.
And then, so any of those pelvic girdle signs or big musculoskeletal contributors from the outside, then they see osteopaths. So he also examines, obviously, gynecologically and neurologically, and including that, the pelvic floor muscles. So if they have significant pelvic floor tightness or weakness or leaking, but mostly we see tightness, pain, then he would send them to the pelvic floor physio.
He doesn't send the pelvic floor people to you then?
No, but they interrelate. That's right. And sometimes we would do an internal, but not very often, because we have the physio that's sort of that realm. And then so it's, even though the roles do cross, it's easier for the patient really to know, oh, okay, I'm going for internals, and then they know, oh yeah, okay, I'm going now for the external, and this is this. So
okay. That's interesting. That's interesting.
Yeah, they do cross, especially maybe say like coccyx that have fall. Then our pelvic floor physio will say, no, go to the osteo, because she doesn't really do that. She's really it's they do bowel, bladder bowel incontinence and pelvic floor function. Yeah.
So if you're dealing then with a coccydynia type patient, are you then mainly working externally with the pelvic floor, or do you do internal work then, or are you more structural?
Yeah, that's right. Like I tend to work externally first, and then give them the options and the choice, and then then if it's still a problem, we would do internal. Yeah. And then sometimes they're seeing both the pelvic floor physio and us, but generally, often they are quite often, but say for coccydynia, I think because Profank is very and the other gynecologists are very good with their examination, that they pretty much can pick the tissues that are going to be stubborn, let's say.
So they're quite good at that pre-screening role then, in terms of their hands-on skill, if you like, with that that screening evaluation. Then that's something that you're comfortable with, that they're not missing relevant patients.
No, well, that's true. I'm just thinking I've gone out of focus. No, over the years there. Knowledge of osteopathy is increased such that now we get a lot more than just the external, pelvic girdle pain plate, which was the original. So we do get a lot more things, and particularly if they're very sensitized and they flare with the internal pelvic floor physios. So that can be very good, because they,
And have you found anything? Have you found anything sort of moving into the field then of the other myofascial, pelvic connective tissue, visceral dynamics, or how are they comfortable with that, or not yet, or where do they sit with that?
That's a good question. That was also a good question actually when we're first moving into there. We have the same clinical system so that everyone can read your notes. So then it was like, okay, what do you write in the notes? Because when you start to write things down, it does seem like, oh, really? Can we really do that? I know we can, but it's a little bit hard for medical doctors sometimes to comprehend that, oh, okay, we can feel that degree of, the degree of palpatory skill needed. I tend to stick to the myofascial structures that then influence the viscera, and I write it in my notes like that. So they... and they're varying in their knowledge of osteo. So Profank probably has the highest because I work closest with him, and then the others are close behind, but they still probably are not quite on board with that as to when you would refer.
Yeah.
I mean, when you've got visceral dysfunction, you've always got musculoskeletal, generally got musculoskeletal, because we tend to get them anyway, but
yes.
they haven't quite made that jump.
Yeah.
And the patients, sometimes the patients find it hard to, I just don't quite understand unless there's kind of a solid thing, you know, like you know, So,
Yeah.
but we still, like, once they come and they love it,
Yeah.
then they are fine. Yeah.
Much easier. And so with the actual notes then, in terms of the phrases and terminologies, do the other doctors actually know what you're doing, or are they sort of just saying, well, they're doing something hands-on? Does it make sense to them? Do they?
Yeah, that's a good question. They would, I mean, you know, we've done a few in services here and there, but and I've treated a few of them, so they do know. Yeah, so they're pretty much do know, but they probably, not all of them know the capacity that we could still go a little bit further. Yeah.
So with that then, in terms of apart from coccydynia and the sort of just giving general mechanical pelvic support, do you do anything particular with certain conditions such as the pudendal neuralgias, or are there any certain condition or patient groups that you sort of are really adding a big thing to that the others were lost without you, so to speak?
So most of our day is pudendal neuralgia and pelvic girdle pain, but quite severe. So, you know, ones that can't really stand on one leg because it's quite severe, you know, SOJ or victim. We see a lot of the mesh injured women, and they tend to do quite well with because they've got pelvic girdle on top of that. But the neuralgias are probably the biggest one. And then we see a lot of visceral hyperalgesia as well. So the endo, adenomyosis, all of those, and the hormonal. Yeah, but pudendal neuralgia is probably the biggest one for sure.
Yeah. So what's your... I was going to say, have you got a favourite go-to technique to help you release? Do you do any of the neural techniques or anything? Just how do you? What's in your head when you first think I've got to look at this patient for their?
So I actually teach this because we've got sort of a little bit of a protocol happening, because the pudendal neuralgia patients are often had it for a while because they've had trouble getting a diagnosis. So that's much better. So it used to be on average 8 years to get a diagnosis, and now because of the internet, and we've really overdone our website so that people would put in their symptoms and find us, because it's not a very it's not a how's your vaginal pain. It's not a very common conversation. So we do see people now very early postpartum, which is good. And, you know, within that first year, which we never saw when I first started working there, 8 years, 9 years ago. So that's progress. And so what I tend to do is always sympathetic, calming down. So good old rib raising is always the go-to at the start. And then I, do probably... just anything big mechanical in the lumbars, but it's pretty much all indirect because they're very sensitized. So rib raising, then path of pudendal nerve, so upper lumbars, sort of, quarter equina type thing, and then SIJ. So I tend to do indirect to the long dorsal ligament, and then as that, very, it's very continuous to the sacrotuberous. So I treat that as a structure in itself as well, and then any muscular tightness. Often the obturator externus, a very favourite of mine that I learned from you, actually, the obturator externus. That's excellent because, Alcock's canal is part of the fascia of the obturator internus, so they respond really well to that. You have to choose when to introduce it, though, according to their sensitivity. It's really basic osteopathy. Like most of the day is sympathetic, parasympathetic drainage, getting that walking cycle going again. And lots of them actually have quite severe, often if they have pelvic girdle pain as well as pudendal neuralgia, then they're the tricky ones, because often we need to rehab the pelvic girdle, but that can set off the pudendal neuralgia pain. So we see a lot of these. It has to be very, very slow and steady, or they can really flare. And often we see that, yes, they've been diagnosed you know, with the pelvic girdle or with low back, say, and then they've been really rehabbed a lot with the classic kind of back rehab, core, and glutes, and then they really flare up. So they can be quite scared of exercise and things by the time they've come. But they tend to respond really well to osteo. They just love it. They love the gentleness, and I mean, it's amazing. Like, you think, goodness, this person's had this for so long, you know, and we only treat them once a month because we're too busy, and they come back and they're so much better. And so
no, it's great.
They're very, very appreciative.
So because obviously with their long-standing chronic pain dynamics, with obviously their psychological or emotional dynamics, do you get much then into, I don't know if you refer for that biopsychosocial or biofeed, you know, the feedback support, or do you give do you incorporate that within your work?
We do, definitely. So lots of them are really traumatized, and they have a degree of post-traumatic stress almost from and often it's from health professionals from not listening and told that's in their head, and so we have a psychologist who works with us, and she does hypnotherapy. So that's actually, it's really good, because often they're like, no, I've been to psychology. I can't talk about, I don't want to talk about my whatever in the past. It's like, well, it's not about that. It's about you coping with stress so it can drop your pain. And you can talk about how you cope with the pain as well, because most people, the mental health issues, are really triggered by the nerve pain. And it's very isolating, and it's, you feel like you're only one. And so they do actually really, they do really like that support as well. And then what we offer too is, if they'd like to get in contact with another woman who's come out the other end, who's much better, then we offer that as well. So I try and just match them up into just connect them via email, so they don't necessarily have to meet, but just connect them via email so that they have someone who's been through it. And because when you have severe nerve pain and for this long, you can't say that you're going to get out the other side. So we also we use the NOE Group, so Neural Orthopedic Institute. So have you heard of them? They're an Australian.
Do you want to just, if you explain it a bit, because that might be something that even if we're not in Australia, we can sort of tap into. So people won't be familiar. So if you...
Okay. So that's so they're called the NOE Group for short. So they're a fantastic group they're physiotherapists, neuroscientists, researchers, and they're educators. So they actually put out the book called Explain Pain. I think it's 20 years. Is it 10 years? 20 years? I think it's 20 years. So, and there's a second edition. So that's basically 20 years of neuroscience in a book that's really accessible to everyone. So it's really fantastic. And then we get the patient to buy the handbook that goes with it. So they have all this knowledge, but how do they get this into their everyday life to, get back to their jobs, having sex, social life? So this is basically, it's a really, really clever tool. So they've divided the nervous system up into when the signals come in from the pelvis, they go to mini brain, dorsal root ganglion, go to the brain. Your brain will decide how much credible evidence of safety is there compared to how much credible evidence of danger is there. And so the end output will determine, how much, if it pumps up your pain or drops your pain down. And because it's very specific to yourself, so your brain will calculate that according to everything you've ever learned, what these signals mean to your life now, and also what it means for your future. So when you have pelvic pain and you're young and you can't have sex or you can't do a wee, or, every time you do a poo, you get nerve pain, that's massive that your brain will actually add on top of that. So this tool is really great because it gets you to do these little things where you actually each day you have a little bit of a framework, so that then it helps you move your perceived dangers, which is pain is a response to danger. It gets you to move them across to safety, and over time your pain scale goes down, and your nervous system changes from being sensitive to less sensitive. So it's really, really amazing tool. And we actually have which I can send you all these links. We send all the patients you know, online resources and different links. So mindfulness, body scans, you know, these books, also websites to help with, you know, better sex for, you know, people with pain or disabilities. Lots of different resources like that. And one of them, we had a woman who had 13 years of pudendal neuralgia, and she had improved a fair bit over, you know, time. She had, you know, a few different things at the clinic, but she still couldn't really sit very long. So, you know, probably only 5 minutes. So I did a little talk on, you know, the new tool, explain pain, and it's called the book, the handbook.
Yeah, sorry, just repeat that, because you just blanked out. The name of the handbook is?
The protectometer.
Yeah.
So, yeah, so pain is a protective response. So then it's trying to work out how to drop your own protectometer so that it, you know, that drops the pain. So
yes.
it's all evidence-based, and it's all based on your own physiology and how you tap into the things that you love. So then you get the good hormones, you move without pain, and then your brain decides, okay, I'm going to descend and modulate that so that when those signals come in, it's saying, okay, it's just me, I need to do a wee. That's all. It doesn't then trigger the pain. So it's quite a powerful tool to have that. And so this woman who had the 13 years of pudendal pain, she came to the little talk I did, and she thought, oh gosh, I don't think this is going to work. Like, how can this work, you know? Oh, but Liz said, you know, all right, I'll give it a go. I'll do it for a month. And there's a handy little app that you can get on your iPad, and you put in your pain scale in the morning, you put in your dangers for the day, you put in your safeties for the day, and they're quite varied. So it can be things you see, hear, taste, touch, you know, people you see, people in it, things you think and believe, which is a very big one. You know, all those things that influence the nervous system, but we don't think about very much in a pain context, but they're quite powerful. Yeah. So you put all those in, and you put your pain score in, and she said after a month I could see that my pain score was just slowly going down. And so she came in, she's like, do you think I should keep going? I'm like, yeah, keep going. So then she's like, look at the graph, look. And then she said after 2 months of doing a really good effort, she said, I was a bit half-assed with that, but now I'm doing a really good effort. And by the end of 3 months, her pain was like down to 2, 3, and it was like 8, 9, 10.
Yes.
And she's just gone from strength to strength. And so she actually found it so good that she wrote a blog about it. And that's sort of one of the steps they put in their book. It's like, once you've come through the other end and you feel, you know, that you've conquered the pain, then writing about it helps yourself, but it helps other people. So
yes, no, that's really useful. Yeah.
So it's really, really clever in that they've really done the whole thing to empower the patient and get active and get better. So that whole de-traumatizing dynamic, as you say, and it's something sometimes difficult for osteopaths, so they're a bit wary of delving into things where they're not qualified to tread, you know, and what can they do that still bridges that divide. But this is obviously, I think there's be some resources there which would be really useful for practitioners. Brilliant. Really fantastic. And often when we're doing work on people, often we are the ones that will be told these intimate problems compared to their GP. So it's actually really good, even if you're not interested in this area, to have a few resources that you can send people to, because it's really, really common, and that's what the research says, that women just don't tell their GPs because they think that nothing can be done for you know, vaginal pain or painful sex or whatever it might be, even though it's very common.
There's way too much putting up with it, isn't there?
For sure. And it doesn't need to be the case.
Okay, can I just ask you a little bit about your mesh patient experiences in terms of the obviously you can do all your work on that outside, but if you do any gentle work to try to release the sort of, you know, fascial visceral tissues, is that something that's actually you do, or do people view it as contraindicated, or where do you sit with that? Because obviously some people can't have the mesh removed, so it remains there. But
that's right. So Profank and I, we did the mesh clinics, and we found that with their clinical histories, like most women who had mesh and had pelvic floor physio, they really flared up with.
Yeah.
So most of them were so severe that the thought of anything entering was way too much. So mostly, as far as osteo went, I just did external only. But there is probably a role for that.
But even just external suprapubic,
oh, yeah.
general belly work,
Yep.
I think more. I was referring more to that rather than intravaginal.
Yeah, definitely. So they really respond well to treatment, but only very minimal treatment. And I mean, I guess we're seeing the worst of the worst, but certainly the ones in the middle part respond really well. And then some I mean, some have so much post-surgical neuropathy that it's that they, any treatment they flare, even indirect. So lots of them have to be, desensitized with medication or, just time sometimes. And although the topical cream, so Profank invented a topical cream with the chemist Alan Hewitt, and that's for vaginal pain. And so it's for vulval pain, and it's particularly good for mesh because it can help stop erosion. So it has estriol for the mucosa, but also amitriptyline for the nerve pain. So lots of women have done really, really well with that, especially the mesh women, because lots of them just cannot bear the thought of any other intervention. But they're very happy to put a bit of cream on. They're very happy to have, manual treatment. But the trauma of the whole thing is too much. And the cost, they don't have, they've spent everything. Everything, lost everything. So the cost is also a problem.
It's a huge thing. Okay, so there's no, just in terms of putting that gentle hands on, then it's no Profank, I wouldn't view that as then disruptive and adding to the sort of mesh inflammation or irritabilities and stuff. Because
no.
Okay, cool. That's really useful.
He's very much of the thought, the physics of the tissues and the meshes and the inflexible structure in a flexible body. So anything we can do to help the body adapt around that mesh, and then it will make them happier. So he's very much of that mindset. But lots of them, we did a little audit where 40 women had their mesh removed, either due to pain or erosion or hugely those problems in a little over a year that was. So it's all varied and traumatic. It was very traumatic. I actually had to go and see a psychologist because it was so, we were seeing maybe 5 mesh women a week, and the story after story were just so heartbreaking that I couldn't sleep at night. I was like, whew, you just want to help them more. It was, horrific. And then it's worldwide, and we have quite a good health system. So it's, America has a massive amount of mesh inserted there. So it's a massive problem.
And so did you find it as a professional, I don't know if there are common routes for interprofessional psychological support like that where you are, or do you have to do it privately as such? Or I don't know if you have an advantage in the clinic that you're working in.
Actually, yes, that's right. So we did make sure we had a debrief every day, like every time we had a clinic, and made sure that we all the debrief is very, very good, and the clinical support is very good. And but no, I did that privately, that's true. There are free lines for patients, and we did speak at a few interdisciplinary conferences, so people were keen to learn about that, but there was not a lot about the psychological support for the carers. Which is fair enough. The women were in more need,
clearly in need, but
absolutely. But that's a really fantastic thing about working in a team is You know, with very complex cases, you couldn't do it alone. It would be very hard, and you need that interdisciplinary support and input anyway, because they're too complex. So,
and do you find then that, so obviously Profank has got that centre at Youre there, all you know, really well established, huge reputation, etc. But the transferability of that, if you like, interprofessional dynamic, and then working with osteos, do you think that is, are people starting to want to do that in other centres, or, you know, are they still a bit wary of it, or?
No, I think it's slowly increasing. Like in Australia, there's many more osteopaths than there's over 3,000 or 4,000 now, which is quite a lot more. And yeah, a lot of doctors are definitely more open to referring to osteopaths. I mean, still the physios are a little, you know, they're more well known, but other practices come to our practice. How do you set it up? How do we do all of that? So we've had a couple of practices that have then modelled, you know, on our practice, so that you know, can provide the same level of care. So it's interesting.
Good. And do you find then with the physios, because obviously although they have their roles and those roles remain defined within your setup even, but do you find that they how is it between you and them in terms of what you're ending up doing and they're ending up doing, and that relationship?
Ours is good, I think, because we do have that clarification at the start that it's sort of mainly internals there and mainly externals here. That our physios don't do any external at all, any body work. They just purely do internal. So it's very clear. But so other practices do have physios who do internal and external. And a lot of physios do, you know, sort of specialize in pelvic girdle. And so it's a bit it's still a hard market to crack into, because physios are probably still better known in the general, you know, getting into that. And you know, I'd love to work in the public hospital, even though I've got 2 undergrads and a master's degree. I said to Prof, what do you think, you know, can I get a job? And the department's like, no, not with the physios there, they just wouldn't
have it.
No. So the political situation is
that's still pretty black and white.
It just depends on the person though. Like some people are like, oh yeah, that's totally fine, and others no. So it's I think it's slowly changing. But when we actually did the public, so we did the mesh clinic at the private clinic, our clinic, Women's Health, and then I went and we did it at the public hospital as well. But the physios there, oh, how come we need an osteopath here to do pain education, and on the mesh we can do that? It's like, well, no, this is a very, well, I mean, this was a very specialised area of mesh, you know, and we had built up that trust. And, but yes, there was a bit of tension there, I must say, within 2 weeks. Which is a real shame, because like we're just sort of trying to, you know, get the patient better.
Yeah, exactly. And everyone can be as you say, upskilled to deliver that sort of care, but then there's no reason why that should then migrate across to being exclusively a physio delivery.
That's right. Yeah, that's right. Exactly.
So have you got any other things in terms of, so you mentioned indirect techniques in terms of the hands-on then that you end up doing. So by indirect, do you mean sort of functional towards ease, or do you mean balanced ligamentous, or do you mean involuntary, or how would you describe what you do in more detail?
I categorize indirect as kind of everything that's into ease. So you can be any manner of those things, but mostly I would do probably, I guess myofascial release is the fascia is the main tissue I think I work in a lot, but I do balance ligamentous tension as well, visceral, visceral fascia.
But just bog standard techniques.
I think all of it. Pretty much, pretty much, and lots of them. It's really just going back to principles. Like if they're congested, you know, you work on the diaphragms and the thoracic cage. Like most of the work is actually the thoracic cage.
It's really interesting, isn't it?
Because it's important. It's so important. And there's a bit of tidying up elsewhere, but Yeah, and because they're so sensitized, that if you start to work on the pelvis before you've calmed down sympathetics, it just it doesn't work as well. It doesn't last as long. It just is like doesn't work as well. So, you know, that's first, well, second year probably, first year.
That's interesting, isn't it? Because I think when people sort of osteopaths, in my experience, when they look to move into these other areas, they think, oh, directly onto the pain. They feel that's absolutely where they've got to be, and then of course it all goes wrong, and then they blame themselves. You know.
Yeah. But no, it's really back to principles. Go back to your anatomy, your physiology, your nerve supply, your drainage, and then apply that, because the unwell patient really responds well to that. They don't like any of the little nitty gritty. They actually need the global help, and they do really quite well.
Brilliant. And is there anything that you would say, well, if I was to get you to not do something, as opposed to here's what I would do, is there something that you would advise people not to do, or to be more wary of, you know, from your experience, as to you know, what to be cautious of?
Well, probably I would say manipulating the sacroiliac joint, because once that is mobile, it's very hard to and most of them we don't really see stiffness in the sacroiliac joint. We see you know, a pelvic girdle that's not weight bearing very well as a unit, and so and to keep treating something that's not changing, I would say, as well. But we really don't use manipulation much at all, unless the patient sort of requests it, and or if they're very stubborn, you know, it's a very stubborn thoracic or something, like very rare though. And don't go straight into the pelvis when they're sore, because you've got a lot of work to do in the musculoskeletal before that. And especially if they're sensitized, like the sensitized patient is very needs to be treated with caution, because they won't come back. They'll flare up, they won't come back. You'll think you've done a good job, but you will be disappointed.
Okay. All right. Well, look, Liz, I think that's really excellent. Thank you so much. I don't know if there's anything else that you want to add, or you know, I'm sure that people can come back onto the group and ask questions after we've posted up the video and things. I'm sure we can always add to the discussion.
Yes, but I would love to come to the UK if anyone wants to.
Yes, I'm sure we can look to encourage you. Yes,
that would be great.
I think that would be excellent. But no, if anyone doesn't know Liz's website, is the Bowerbird CPD that she runs. So do make sure that you check that up, and then we can put some links on there, and then maybe with some of the other stuff that she's mentioned as well. So that would be great. And I think the more we have this, you know, global conversation going on, it's to the better. So we needn't stick to our own little regulatory worlds or small ponds. We need to mix, I think.
That's right. And Australia has the advantage of, like, with research, we I think, like, we have a bit more free reign with research. So we do quite a lot of at the clinic we have a policy of, if we introduce a new technique or procedure or whatever, like speaking, then after 50 cases, we'll audit the procedure and see how the patients have done. And then we tend to, you know, adapt and change to that. And we do lots of little research projects, which one really interesting one that we're about to analyze the data is pudendal nerve block. We added hyaluronic acid. So that's a double-blind crossover. So we're really excited to see, you know, how they did, because lots of them actually, we've done that for quite a few years, but didn't have, you know, and we had a pilot study that showed, some people get 6 to 12 months relief, which is amazing. So if that can, if we can get some good data from that, you know, to transfer that to other peripheral nerve blocks would be amazing, because
Excellent. Well, there's obviously another conversation to be had about all of the research actions that you do and how that all works out. So great. Okay. Well, look, thank you so much, Liz, for doing that. And we'll keep in touch through the group and everything. Okay. Thank you so much.
Right. Thanks, Carolyn. Bye.